Hey everyone, it's that time again. For those of you who have just signed on, please give us a shout out in the Q&A box and let us know where you're from. While you're doing that, I'll take care of the introductions and housekeeping items. My name is Lacey Bergevin and I'm going to be your host today, so welcome. Today we're scheduled for 60 minutes with 10 to 15 minutes of Q&A at the end. Speaking of Q&A, we do encourage your participation throughout the session, so please don't be shy. The Q&A box will remain on your screen throughout the presentation. Please type questions in at any time, and also if you have any technical difficulties during the session, you can seek help in this box with our team. We will be sending the recording via email today with the CE info, and we'll be posting recordings daily in the Facebook group. Our goal is to offer CE credit for all courses. The evaluation and quiz will be sent today, and your CE certificates will be issued within 1 to 2 weeks. Okay, with that out of the way, it's my absolute pleasure to introduce our presenter, Dr. Susan Maples. Dr. Susan Maples is an international speaker in the area of total health, the oral health and systemic health connection, and the diabetes epidemic in America. She also speaks in the areas of leadership, team building, advanced case planning and acceptance, relationship-based target marketing, and growing healthy kids in your dental practice. When Susan is not practicing dentistry, she serves as a leader in helping her profession take their place in the U.S. health crisis. To help educate the public on the mouth-body health connection, Dr. Maples authored the book Blabbermouth, 77 Secrets Only Your Mouth Can Tell You to Live a Healthier, Happier, Sexier Life. In addition, she is the co-researcher in an award-winning study on detecting diabetes in your dentist's office. Dr. Maples is someone that truly captures the carie-free mission, acting in service of fellow dental offices and patients, and we always learn something new when she speaks. We also have Dr. Cooch joining us. He's the founder of Carie-Free and an internationally recognized speaker. He's published hundreds of papers in dental and medical journals, and we're lucky to have him as our resident caries risk management expert. Dr. Cooch, I'll let you officially say a few words and then hand it off to Susan.
All right. Hey, thank you, Lacey, and welcome, everybody. This is our third week. I can't believe it. And we're going to start the week off with a bang today. Dr. Susan Maples is an inspiration to anybody that knows her. She is an amazing dentist, has a commitment to excellence in her practice that is just above and beyond. And you're going to witness some of that today. And she's an incredible speaker, and above all, she is one of my dearest friends. So, Susan, I absolutely welcome you, and I'm excited.
Well, thank you so much. Can you guys hear me well?
Yep, loud and clear.
All right, all right. Well, thank you for everyone for being here. Let's start with a welcome to all your quarantining shelter-in-place friends and looking at this incredible virus. It's actually quite beautiful to look at, isn't it, even though it's such a bugger. And here we are, like for the very first time, I believe, all of America is speaking our language and looking at host immune response. I don't think there's ever been a time when people are looking at themselves wondering, is my immune system strong enough to take a good attack from this bug? It's scary and it's interesting. It presents, of course, quite a liability when we think about, oh my gosh, this is predicted to take out more small businesses than lives. Who knows how long it will be for the economic recovery, let alone for the herd immunity to take place, and how many lives will be changed and lost as a result of this before the vaccine comes. But what about the opportunity for us? I mean, this particular discussion as patients come back into our rooms and we're there face-to-face, one-on-one with them, this discussion about how was it for you and how frightened were you that if you actually became exposed to this virus that it would take you out. that's an awesome opportunity to take a look at what do they know about themselves. I know that on March 2nd, as I was tuning in to see where it was going in the United States, very early on, the scary newscast was interrupted by a very cheery voice saying, the good news is that today is National Egg McMuffin Day, and McDonald's is offering free Egg McMuffins. And Wendy's launched their new breakfast sandwich today, or breakfast menu, and so did KFC. Their sandwich is 2 glazed donuts with a piece of extra battered extra crispy hand battered chicken in between 2 glazed donuts. And that's the good news. I kind of want to say, so when did McDonald's get its own day, and why are we celebrating this? The irony was not lost on me, that 75% of what we're dying from in the United States is lifestyle-related disease that we have a choice about, and yet we aren't too upset about that. We were upset about the possible 3% of the population that if they got infected with this bug would die. And I understand it. It's a gruesome, awful, quick death in isolation. It scares me too. But so should our lifestyle. And so we have a unique opportunity in dentistry to help people really dig deep and look at root cause for disease of all kinds. I think it's time, and I've had this slide in my carousel forever, to switch. I'm sort of challenging conventional wisdom to shift from the routinized examination. Any changes in your health history, yes or no? They usually say no. You tip them back. You're looking around their mouth. You're really rushing through that initial phase so you can get an instrument on their teeth. To a personalized examination where we look at each individual personally, as does this virus. And what do we see when we dig a little deeper, and how can we help the patient emerge from our dental experience one step closer to optimal health, which really all of us want. We all want in our own, we're just wired for wanting to be healthier. In fact, every cell in the body is capable of healing until it's not. And how do we put our body in a state of optimal health? So that's kind of what we're talking about today. I believe that when we see the mouth with superpowered eyes and we see all that it offers, not just oral disease, which we're used to looking at and knowing the manifestations in the body, but how are all the systemic diseases, including metabolic diseases, showing up in the mouth, and what can we see here? So hopefully today you may pick up a few tips. I think that the opportunities for us in terms of antibody and antigen testing for the COVID virus open up another avenue for us to take a look at total health. The opportunity for us to offer vaccinations in our office, which I believe we could and should be doing for HPV oropharyngeal cancer. Strengthening immune systems by helping people understand what makes a strong and weak immune system. Identifying comorbidities, those factors that help, that sort of interplay to take our health down, to help people demedicate. That doesn't mean that we can officially tell a patient to stop taking a physician-prescribed medication, but we can help work with physicians and help people get their bodies to a point where they are less dependent on multiple medications and more looking at the root cause of the disease. Certainly to help with addiction and habit control, we're going to see a lot of increased addiction after this period of time, and also people who want free of addiction. If you think about somebody that smoked all the way through this period, still wondering about how their lungs are going to meet this bug, it might be a great time to help someone reduce or eliminate tobacco or cannabis habits. And then, of course, identifying depression and anxiety. Anxiety disorders are going to be at an all-time high after this, and we can help with those things. So those are just a few of the opportunities that I see in terms of helping people from a total health perspective. I was raised, fortunately, with a woman, a grandmother, who in human form embodied humor and wisdom and heart all together, and she was one of my heroes. But She raised us knowing just 2 poems on her refrigerator. One of them said this: "You're sure you're right? How fine and strong, but were you ever just as sure and wrong?" And we've been wrong a lot, both on a personal level, but certainly on our profession. So as I speak today, I just want to ask you not to be careful about the fervency with which you get on your high horse as a health professional in any arena, whether it's speaking about COVID or periodontal disease or heart disease or stroke or what we know about inflammation or diabetes, because no matter how high you sit on that horse, you will come down a notch. The evidence is always mounting, and I like to think that we're learn-it-alls and ask-it-alls, not know-it-alls. I know that people put a lot of stock in our words, and we have to be very careful about, again, the fervency with which we are sure. So that's just a little caveat. But here's a perfect example. We never guessed in our wildest imagination that we would be able to link the pathogenesis from periodontal disease all the way to coronary artery disease or atherosclerosis or heart attack or stroke. And when you first heard it, I'm sure it was like, what? What are they talking about? We've always been taught that periodontal disease was its own isolated disease, even though, of course, the gums share a blood supply with the rest of the body. We bought it hook, line, and sinker, and then had to go around and tell people we were wrong about that. First, we had to notice some significant links. In other words, a high number of people had periodontal disease also had heart disease. That wasn't a big surprise, considering the percentage of the population that has both. We'll look at those percentages in a couple minutes, but it wasn't a big surprise that there was a big overlap. The question is, could we prove how it works and why it works? Even for my entire career, we've known that periodontal pathogens were linked to endocarditis, and so we've been medicating for that with various ways, shapes, and forms over the years. But this is an interesting phenomenon. So let's take a better look. This is a story many of you are aware of, that, or a paper that many of you are aware of from 2016 that Bale and Doneen wrote on high-risk periodontal pathogens and how it contributes to the permeability of the endothelium. And I'd like to kind of walk through that a little bit so you can see how that actually works. First of all, I said I would talk about numbers. Over 30 years old, half of us have periodontal disease. That's crazy, right? And by 70 years old, 70%. That's an easy number to remember, 70-70. So it's a very, very prevalent disease, and so is heart disease. Heart disease is our #1 disease, cardiovascular disease, and it affects 1 in 3. Soon to be 1 in 2. Now, this has not always been the case. In the history of the human race, this has happened in the blink of an eye. And we have to ask ourselves, why has heart disease increased so rapidly? And we'll talk about some of those things. But the problem isn't stopping. We are, as an adult cohort, 42% obese. We will soon be 42% obese overall. Children are at about 30%. We're really in trouble because although we're all aware of obesity and diabetes and cardiovascular disease, the awareness isn't helping. We are literally getting sicker by the minute, and it's happened so quickly. Again, if you look back on the human race, it's happened in 4 decades, which is just crazy, over 200 million years. So we're really in trouble, and that is a fact. Periodontal disease is linked to 57 different. I know you've had Doug Thompson speaking to you already, a good friend and colleague, and I know he's talked about a lot of this with you as well. Periodontal disease is linked to 57 different diseases, and I just have a few of them here. There's so many. And there are more all the time. And so we'll talk about why that is and why these pathogens that grow in the mouth permeate into the vascular system, create such havoc. But we have to also recognize that the disease itself is complicated. If you look at these two mouths, you will very clearly recognize they're both diseased patients. And yet they look so different, don't they? The bottom one is a smoker, and you can see there's very little plaque in this picture. There's also very little borderline bleeding around the free gingival margin. There's not that red line. There's not heavy loads of plaque. In fact, we see dark red from the free gingival margin all the way up to the mucogingival junction. This is chronic inflammation, but it could be that scaling and root planing isn't going to help this patient. And why is that? And then we see the more acute patient above that looks like, boy, if we got this person cleaned up, we'd see a tremendous improvement, and our efforts might really help this person. But it's understanding the very complicated root causes of this disease that help us make a good diagnosis. It is high time that we move on from our old paradigm of thinking that we're going to solve this disease with a set of sharp instruments that fit against the tooth well, and that a piece of floss is going to do it for them at home, since they haven't been flossing, and most of the disease we find is between teeth. This is really old school thinking, and though we can use these as tools, we are getting a more sophisticated audience. The public is being made aware that this is not doing it for them, and yet we in our own little offices have such difficulty with change, of moving away from thinking that what we're doing for the patient is going to solve the problem, as if they're in for gallstones and we're going to remove a gallbladder and make it all go away. Just doesn't work that way. In 2016, interestingly, the same year that Bale and Doneen published that article, the American press came out and told the world that flossing wasn't helping. The American press did not release what studies they based that on. We didn't know if it was about caries, if it was about periodontal disease, and the more we bugged them to release it, the more they just said no, they weren't going to. But the world became aware and started asking you questions. It was an awesome opportunity as patients came in and said, see, I told you it didn't matter if I floss or not, to help people understand the complicated nature of the disease, instead of just getting upset and irritated that all of our efforts were for nothing. In fact, one patient came in to me and said, okay, doc, the first day I saw that flossing didn't matter was the day I started flossing. And I thought, what is this about? And he said, that's right, because I looked on your Facebook page and one of your team members posted this. Flossing is the equivalent to wiping your butt cheeks and skipping the crack. And I finally got it. And I thought, oh my gosh, that's crazy. Who wrote that? It was Molly. And so anyway, it was, a lot of people felt like common sense indicates that, you know, why would you not want to floss, including all of us? But it was an eye-opener that it does not actually predict the difference. Most of us understand that you can't floss to the base of a 6-millimeter pocket. Once there's a 6-millimeter pocket and the flora, the microbiome of the pocket starts to worsen, that we're not touching it with a piece of floss. So let's look at periodontitis as an entirety. We start to look at the host response to a bacterial challenge, just like in COVID, the host response to a viral challenge. We also have, of course, viruses and funguses that are at play here, but let's just look at the bacteria. We often diagnose periodontal disease by putting a probe into a pocket, measuring for bone loss, and pulling the probe out and looking at bleeding response, which is a sign of activity or acute inflammation or active inflammation. This is unfortunately end-stage disease. When I say end, we're not losing a tooth at this point, but it is already in process. It's already a systemic process by which we're catabolizing or getting rid of bone. And it doesn't start there. So when you put a probe into a 4-millimeter pocket and it's bleeding, and you think, well, I have a couple minutes extra, I can just scale that area and make that area better, we are basically stealing the disease from the patient, not even allowing them to see that this is a systemic disease that they are already part of, and we need to back up and take a look at what is the root cause, help the patient understand it, get from under it, surround it, and then think about appropriate treatment methodologies. It starts with a bacterial challenge for sure. Why does one person, when we do salivary testing for adults who kiss one another, husband and wife, for instance, why is it that their microflora might look very similar and one person has much more periodontal damage than another? Again, it comes down to host immune and inflammatory response. And this little red box deserves our attention. We're not going to have a lot of more time on this today, but it behooves all of us to dig into what makes the difference in an immune system in terms of its response to a bacterial challenge. We also, again, need to look at what bacteria are there and really give them some value, which ones are most dangerous, more moderately dangerous, and least dangerous to the human body. And then we look at the connective tissue and bone destruction. What are the forces at work there? So one of the things we haven't been good at looking at in terms of this whole process is what's the genetic component. And even though the genetic component may be only 5% of our population, if genetics is a factor, we ought to know that. And there's genetic testing that we can do through, again, a single drop of saliva swished with saline solution and spit into a cup, we can find those genetic factors. It turns out that genetic factors are closely linked to the genetic factors in cardiovascular disease risk, which is no accident. We'll look a little more carefully in a moment. But then there are the environmental factors that we as a dental community typically overlook. We might tell someone that smoking destroys bone because we know that's true, but we don't really understand the pathogenesis of that, so we typically leave it alone, and most of us in our offices don't have really solid tobacco cessation programs available in our office to offer people evidence-based approaches to tobacco cessation. It is the most insidiously addictive drug on the planet and very difficult to eradicate an addiction to nicotine. And I believe if you're not doing that, you are really not treating the disease in a tobacco-dependent or smoking-dependent patient. Then there's diabetes. Diabetes has a bidirectional relationship with periodontal disease. In other words, hyperglycemia, or someone who's not able to control their blood sugar levels, is has a much higher propensity to have active gum disease and vice versa. If you have active gum disease and you're diabetic, good luck getting glycemic control. So that's what we talk about when we refer to the word bidirectional. Each makes the other worse. Okay, this is a chart you probably have seen. It's originated by, again, Dr. Brad Bale and Amy Jonine, and it's really about inflammation and how it affects our blood vessels. So when you look at the root cause of chronic inflammation in the body, by the way, inflammation is good. Without it, we would die. Acute inflammation is what helps us heal. Chronic inflammation takes its toll on our bodies. If you look at the roots under the tree, periodontal disease and endodontic disease, that is infections from periapical lesions, are definitely roots under the tree, but not the only roots. There are multiple causes of chronic inflammation, including low vitamin D, insulin resistance, which is the precursor to diabetes, obviously prediabetes and diabetes, obstructive sleep apnea, nicotine. So there are lots and lots of other ways that food additives and sensitivities and acid reflux, which 60% of us have. I mean, these are all inflammatory loads on the body that show up as chronic inflammation. Chronic inflammation impacts the endothelium, the lining of all of our blood vessels. So Bale and Doneen had suggested to us that if we cut the blood vessels, took all the blood vessels out of the body and cut them open and laid them out on the floor, they'd cover 6 tennis courts. It's an enormous surface area. And in the first little cherry under the tree, that's a blood vessel cross-section. And in that lumen is where the blood is, and that dark line is the endothelium. Again, a strong, solid endothelium helps block the invasion or penetration of outside stuff. The outside stuff sneaks in and takes over the wall of the vessel, and what do we usually attribute that outside stuff to? We usually call it lipoproteins or lipids. And it's the quality and quantity of those lipids circulating in the blood vessel that has occupied our attention. So we get people on statin drugs to reduce the amount of bad or small, tiny lipoproteins or lipids, that little tiny droplets that can permeate those walls and collect, or permeate the endothelium and collect inside the walls to make a plaque. Well, what also permeates the inside of these vessels is bad bacteria connected with macrophages that create foam cells. So little pockets of inflammation that also form inside these walls and can make a bacterial mass. And so when we take a clot, so if you move along the line here, when you look at the puncture of the lumen by burst of that plaque into the lumen, when we have a heart attack, we can take that little clot out of there that has caused damage or lack of blood supply to a part of the heart. We can do a bypass surgery and take that clot out and analyze it and find out that it's teeming with oral bacteria. What are some of the bacteria that migrate from the mouth to get into that vessel? We'll find that out. But before we go there, let's clearly understand that the inflammation in the mouth causes cytokines or cell-to-cell mediators that actually stimulate the weakness of that wall. So it's two parts. It's one, the periodontal infection causes the blood vessels to become weaker or more penetrable, and two, the circulating bacteria that moves through the bloodstream from the mouth can be one of the dangerous factors that penetrates the vessel and causes havoc. It's not just in the heart and the head, not just stroke and heart attack, but in lots and lots and lots of organs. In other words, we've now shown a 39-week stillborn baby, fetus, who died in utero, teeming with oral infection from Fusobacterium nucleatum from the mother's mouth, who only had pregnancy gingivitis, would not have been diagnosed with periodontal disease. So this is frightening that we see now that we can do DNA testing to identify not only what are the bacteria that are causing havoc with the body, but where did they come from. We would have assumed that in that particular pregnant mother it would only have come from the colorectal or vaginal canal in the past, and now we can find that it was only in the mouth of the mother. So when we look at this, it may look innocuous to us, but to take a picture of this and show the patient, let's zoom in to this little red puffy triangle that I probed and it bled. Let's zoom in to see what's going on in there. Well, the bacteria from the mouth has penetrated into that little area, and now the blood vessels are engorged, the little capillaries are engorged. They're engorged because they open up a huge highway for white blood cells to come into the area to fight the bugs. Now, with the white blood cells obviously come red blood cells. That's what makes it erythematous or red. And, of course, extracellular water. So the inflammation, the puffiness, comes from the entire inflammatory process. And if this were acute, where it was just there for a short time. The body would take care of it and get rid of it, but unfortunately, it goes on and on and on. And in that bloodstream pass some of those bugs that become pernicious and hardy enough to travel through the bloodstream and end up in far-off places where we don't want them. So when we look at this video, this is called White Blood Cell in Pursuit of Bacteria, and the video doesn't work on here, but you can see the macrophage is chasing after the little black bacteria bug, and in the gut of the macrophage it processes it, and then it poops out the excrement. These are cell-to-cell mediators or inflammatory cytokines that circulate, and the blobs are the red blood cells hanging around to help with oxygen transport. So these traveling bugs, actually, this comes from a study by Wenke Borneke at University of Michigan. They survive and multiply inside other cells. They travel through blood to infect other organs, and they have tentacles like an octopus that can weave inside endothelial cells where there are only 10 to 16 layers in a healthy endothelium. What are the pathogens that cause the problem? Well, AA, PG, TF, TD, and FN, Fusobacterium nucleatum, are the 5 most dangerous according to Bale and Doneen's study that you saw earlier. And we can test these in saliva, and right, we should. We should be testing all of our periodontal patients, because if we are truly going to have an antimicrobial approach, a full mouth disinfection approach to this disease, we need to know what we're fighting. It would be really silly to show up in battle and not know what we're battling against. And so in this particular oral DNA sample, the patient did a saliva test before, and then we, as Doug does, test for 6 weeks after no bleeding. Not 6 weeks after treatment, but 6 weeks after no bleeding, and this can take quite a while. Sometimes when we can't get no bleeding, we'll test again to see what pathogens we're fighting and maybe go at it again. But we want to be armed with the right antibiotics. This is an interesting study of JADA 2018, I can't read the date there, 16. Why is antibiotic prescribing by dentists increasing? This is frightening to me, that in this 17-year period between 96 and 2013, antibiotics declined overall, and physician prescribing declined 18.2%. Dental prescribing increased 62.2%. I could go into the reasons for this, ignoring our new perioperative antibiotic coverage for heart disease and prosthetic joints, and over-medicating for wisdom teeth removal and implants and everything else. But this is negligent on our part. And I feel somewhat responsible for this because as a dentist, we've been prescribing fairly haphazardly for a long time, not paying attention to the fact that we have superbugs developing, we're losing antibiotic effectiveness, and we also are creating a lot of gut problems, including C. diff and other microbial challenges in the gut. So when we prescribe antibiotics, we ought to be doing it carefully, and if at all possible, we ought to be knowing what bugs we're going for and doing the sensitivity assay, which oral DNA does for us. We also treat with an antimicrobial locally, so both for treatment, for use in our periodontal treatment and for home treatment during periodontal therapy, we're using the CTX4 rinse, which has been a blessing to us. I don't know if you guys are aware that chlorhexidine is both cytotoxic to fibroblasts, but also osteoblasts, causes staining, a lot more problems than it's worth. It doesn't taste good. And this treatment rinse, although it tastes a little like pool water, it doesn't taste like a delicious mouth rinse. It is antimicrobial in its approach. It has a pH neutralizer. It has sodium hypochlorite, fluoride, and xylitol. So we're very fortunate to have it, and we're using it both for irrigation and for home treatment throughout periodontal disease treatment. But again, we don't want to use this alone. We're really looking at, is an is a systemic antibiotic necessary, and if it's necessary, at what strength and at what dosage. So now we're doing full mouth disinfection in a shorter period of time, which means we're not getting behavior modification over the length of time we used to treat the disease when we would scale, well, the way I learned it was one quadrant a week for weeks. So we had about 6 weeks before 4 quadrants and after of treatment, during which we help the patient with behavior modification, recognizing that home care is definitely part of the mix. And now we have to be, I'll talk about that in a minute, now we have to be a little more conscientious about how we do that. But we have a genetic test that Oral DNA offers also, and here is the genetic test I referred to. It measures 8 gene markers associated with inflammation and critical factors in both periodontal disease and cardiovascular disease severity. When we get positive results for this CELSIS-1, we share it with their physicians, of course, to let them know their genetic risk factors for inflammation and cardiovascular disease. I'm not going to spend a lot of time on that because I really do want to spend the majority of the rest of the time taking a look at type 2 diabetes and how it affects periodontal disease in both directions. Type 2 diabetes now affects 30.3 million. Actually, that number's much higher now. It's been 2 years since the new numbers have been out, but we are now 1 in 11, or actually closer to 1 in 10, diseased with type 2 diabetes, and that is unbelievable. Diabetes doubled in 5 years from 2012 to 2017. We went from 16.2 million in 2012 to 30.3 in 2017. Doubled in 5 years of the human race. It is projected to be at 1 in 3 by 2050, and that is not based on just a extrapolated projection of the numbers. That is predicted because we are now 150 million. That's 1 in 2 in the United States insulin resistant. What does that mean? It means that we have insulin circulating even though our hypothalamus and liver can't recognize it. So the insulin pump doesn't turn off. Why is that? It's because we're overexposed to fructose. We're consuming 22 to 40 teaspoons of sugar a day, depending on what demographic you're looking at. And it is absolutely outrageously dangerous to be consuming sugar at that level. And yet, the food industry keeps marking up the bliss point and pouring more sugar into the food. And of course, with that, we get more disease, more medications, more dry mouth, more oral disease. And so if you think about periodontal disease and caries increasing, it isn't just because we're not doing our part well enough, and it isn't just because the patient's not doing their part well enough. It literally is because we're getting sicker and sicker because of our food supply, and that is really the primary cause. I don't know if you guys have Rob Lustig coming on. Maybe Kim can tell us that. But if you haven't taken a look at his work, just look at his YouTube video this afternoon, Sugar, the Bitter Truth. It's had, I don't know, over 5 million hits, but it's he also wrote the book Fat Chance. Worth looking at the pathology related to sugar. But moving forward, globally, the number of people with diabetes from 1980 until now, this is World Health Organization statistics, has moved to 422 million. So this is not just a U.S. problem, it's global. We are the only animals on the planet who can't regulate our glucose, except for dogs, and I have my sweet dog nuzzled up right next to me, keeping me company during this webinar. And you know, my vet wants me to tell you that it happens to the animals we hold in captivity too, because they too are eating commercial food. But animals in the wild don't have a glycemic problem. They move around the planet to eat their food, and they eat from the source. So we have taken the sugar out of the plant, thrown the plant away with the antidote to the sugar problem, which is the fiber. which causes the glucose to move slowly through the gut. It never comes out of the gut. It goes in the mouth, comes out the poop chute, never comes out of the gut, and it slows down digestion, allowing the glucose to be released slowly, which mitigates that insulin response, so the insulin pump is able to keep up. When you dump glucose into blood sugar by drinking it down or eating it in its most pure form, it is a bolus of sugar that hits the body, and the bloodstream has to respond by pumping out a bolus of insulin. And so this is what messes up our pancreas, hypothalamus, our whole regulatory system. And over time, we aren't able to regulate our glucose. So as long as diabetes is on the increase, periodontal disease will be also. And as long as it's not detectable by the human eye, we're going to be treating unknown diabetics. And so we need to take a look at that. This is how we choose to treat diabetes on the left, by offering medications, which is what our healthcare system has chosen to do with most of our lifestyle-related medications, is to develop wonderful technology that helps erase the disease, or does it. Now we've added toxicology on top of that. We've added insults to the body in form of chemicals that might help put the patient in a passive approach to their disease so that they could not even know they have it. They can return to their habits and problems that got them into trouble to begin with, instead of saying, wow, wouldn't you rather fix this by eating the right foods? So this in a dental office is a huge opportunity for us. We actually are the ones we've been waiting for, because in all of healthcare, there are no professional preventionists except hygienists. There's no one that the public associates going to on a regular 6-month basis without any disease. In fact, most people go to their physician only for problem-focused examinations, and they're going in with one problem at a time and getting 7 minutes of the physician's time, including electronic medical records. So we are who we've been waiting for if we're going to try to help people turn this ship around and help their own bodies on an individual basis dodge the bullets of lifestyle-related cardiovascular disease, diabetes, reflux, and the like. So let's take a look at where this 6-month preventive relationship came from. Did it come from research? No, it didn't. It came from an old Pepsodent advertisement that was brilliant. Pepsodent told the world if they visit their dentist twice a year and brush their teeth twice a day, they could have strong, healthy teeth. And for the most part, we continue to tell our patients that, even though the evidence does not support that. There was a third piece of this advertisement, one that we overlooked until now, I hope. And it says, eat correctly. Where is it that the dental office became the primary responsive health professional to help patients learn how to eat correctly? People are so confused about what to eat right now. It's unbelievable. They don't know whether they're going vegan or paleo or intermittent fasting or high protein or low carb or gluten-free or avoiding lectins. I mean, they're so confused. And so it is up to us to become very astute in our ability to help people choose personalized approaches to food and to exercise and to sleep and airway. In the meantime, we will continue to see the 4 diseases that we treat in the mouth increase despite our 6-month prophies. And if we aren't careful and we don't take our rightful place at the table, insurance companies will eliminate the 6-month prophy too, recognizing that what we're currently doing inside of our old-fashioned paradigm isn't making a hill of beans of difference in the disease rates of these 4 diseases. So it is really responsible of us, for our profession, for our children, for our human cohort, for our country, to be able to dig in and learn more, which is why you're here today, preaching to the choir. This is diabetes. We recognize that a scratch in the foot can lead to an amputation of a foot. It's the biggest reason we lose kidneys and limbs and eyesight. But this is also diabetes, and This is in a healthy, otherwise healthy person that you might look at her teeth and say, wow, she doesn't really have, she didn't have gum disease and she didn't have caries, and now all of a sudden she has really quickly deteriorating periodontal disease, and this is what the x-ray looks like. Now, many of us would be anxious to get a sharp instrument in that pocket, and if you knew that that person was extremely unstable diabetic, you would think twice before you'd want to dump dangerous bacteria into the bloodstream of a diabetic. So we need to start to recognize that that's an oral manifestation. The evidence suggests that perio changes are the first clinical manifestations of diabetes, believe it or not. And yet, because we don't think of it as diabetes, we think of it as a plaque problem. Somebody's not cleaning their teeth well enough. They haven't had their teeth cleaned enough. They haven't had a good cleaning in a long time. We overlook that this might be diabetes in front of our very eyes, and it may not be as severe as what you just saw. The oral signs of diabetes are gingivitis. Yep, gingivitis. Periodontal disease, 94% of diabetics have periodontal disease. Dental caries from salivary hypofunction, oral infections, ongoing infections, candida or yeast, which we don't have time to talk about, but we now test for 9 strains of yeast. Only one of them is albicans, the one that's white, so that we have to move higher on our radar. Taste interferences and neurosensory disorders, disorders in the way patients feel numbness or pain. So when we look at diabetes, 76% are diagnosed and 24% or 7.2 million in our country are not diagnosed, which means with a prevalence like 1 in 11, soon to be 1 in 3, we ought to be able to say every periodontal patient we need to know their diabetic status. And if they don't know because they haven't had a recent test, we ought to be able to give that information to them and treat them accordingly. We should be able to test A1C right in our offices. We do it routinely in my office. Absolutely 0 patients who have periodontal disease will undergo a diagnosis and a treatment plan for helping eradicate that disease and manage that disease without knowing their A1C. So that means that we need to be much more astute about who we're going to test for A1C besides perio patients, so that we can predict and preempt this and not just wait till they're full-blown perio patients. The American Diabetes Association guidelines for screening state clearly that they're looking at the BMI, the basal metabolic index, which talks about overweightedness, and that you also, for any patients over 45, and if you're normal, that you test again in 3-year intervals. We, in order to figure a BMI, would either need to weigh the patient or ask their weight, and I just decided I did not think that dental offices really wanted to engage in that, and that would be a big barrier for a dental office. So I decided to take on a research project with the head of endocrinology at Michigan State University, Saleh Aldazuki, and we tested 500 of my patients who had no history of the disease to come up with a screening tool that did not include BMI, self-reported overweightedness. And the way it was reported is to look at 2 questions that would take the place of BMI. But what we did was we tested 500 patients with no history, not even gestational diabetes, diabetes during pregnancy, and we compared their A1C levels. We used the National Glycohemoglobin Standardization Program, so we got really good diagnostic levels to the answers on the screening tool that we devised. And we came up with a screening tool that had surrogate measures or substitute measures of overweightedness. One of them was if your waist size is over 35 for women and over 40 for men, and if you can self-report a 10% above your ideal body weight, we use that as a checkpoint for overweightedness rather than the BMI. And that most patients can answer one of the 2 of those pretty readily. And so we developed this, and if you want access to this, just go on selfscreen.net when you get off of here, and you can just push on my name, and it'll bring this page up, and then when you push on the scroll down a little bit, it'll pull up diabetes, and you push on that and take the diabetes screening test right on your phone. This tells you whether you need to be tested for A1C. If you just have 3 risk factors here, one would be overweightedness plus one other, or 3 not including the overweightedness, it'll value your risk factors to be able to determine whether the patient needs an A1C test. And although the United States is the only country that has not approved A1C testing, chairside for, or I should say chairside, in-office point-of-care testing for diagnosis, they only use it as a monitoring. And I don't know why this is. There is a political battle going on, but you're not surprised by that. But we can use this as a data point for sure to be able to refer to physicians saying, these are the risk factors, and here's the A1C, and here's what's going on in the patient's mouth, and for this reason we're referring to you for definitive testing. When we work hand in hand with a medical team, we not only allow them to see who we are in the community, and raise their esteem of us, but we can gain referrals from them, and we can work in collaboration and in a measure of advocacy with our patients to help our patients gain glycemic control and take a look at their overall health with their medical providers. I'll talk about that a little bit more in a minute. But in any event, we ought to know these A1C results, and we ought to be able to do it in our offices. In our office, we use the Siemens DCA analyzer. It takes 6 minutes. Generally, one of our hygienists just calls on the little walkie for someone to come do a quick A1C test, and everyone in our office, every clinical person is able to do it, has been trained to do it, and we had to get a CLIA waiver to be able to do this, but not difficult to do. We run the test, and in 6 minutes, somebody brings the test results back to the hygienist. It's nice because this is a measure of 3 months average circulating blood sugar without having to fast, and 3 months corresponds typically to the traditional periodontal maintenance prophy, so it works out really well, and we always share the results with the patient and the patient's physician as well. This is another, this is called the Affinion. This is a 3-minute test. It's another machine that you could purchase, and this one is very inexpensive. This is a pre-calibrated machine, a little tiny device that comes inside of a box of kits, and I think this is $100 for 10 kits plus the device. When you're done with the kits, you throw it away and you order it again. So this you can buy through Henry Schein, and you can test your patients using this. The pre-calibrated machines show in the literature a little more variability, but I've been using this anecdotally just to do my own empirical research inside of my office, running them on both for some time, and I find this A1C now very accurate. So I think it's a nice one. This is the JAMA diagnostic test interpretation that says it's best if you're using a pre-calibrated device to understand that it's not, that it has its limits, and that it's best to use one of the calibrated devices that we're calibrating monthly, like the 2 that I showed you earlier. We also recognize that A1C shouldn't be used alone because the values over 6.5 are not as predictable. But we now know from a really, really good study that periodontal pocketing is the only other risk factor we need. If the A1C is greater than 5.7 and 25% of the teeth have 5-millimeter pockets, or 4 or more teeth have been lost, we can diagnose prediabetes or diabetes using that A1C with a 92% confidence, which is nice, and many of our medical colleagues don't know that, so that's a good piece of information to share. I wanted to mention that because behavior modification isn't happening now during the periodontal treatment phase, we only have about a week to 10 days of antibiotic coverage, during which we are usually prescribing a very, very hefty probiotic also. We're trying to keep the patient on antibiotics as little time as possible to surround this. We really focus on what we call self-prophy, making the patient giving the patient the skills, beliefs, and habitual behaviors they need to be able to have predictable success in their own bathrooms. So we know that part of it belongs to them, and we do this all before we start treatment. So, and we don't just show up and teach them how to do it. We want them to demonstrate to us. So this is how we do it in kids. With our children, we don't polish teeth at all in our office. We do what we call self-prophy. We stain the plaque on their teeth, and then in a lighted magnified mirror, children have a choice of whatever they're going to use to clean their teeth. We want them to learn how to use all of these things. We know that power brushes are much more effective than handheld brushes, and yet we never see people use those. So for children, we do this in a lighted magnified mirror, and we monitor their behavior over time. So we're helping them build skills, beliefs, and behaviors around self-care. And they have to actually earn the right to go through braces. If they can't deplaque their teeth well before braces, imagine what it's like after they get all this hardware on. Then when they get the hardware on, they come in for a self-prophy, and they're returning to us every week or two until they can master that. We know that decalcification happens inside of 6 weeks. We certainly don't want to keep them on 6-month recare if they're not able to do good self-prophy skills. Well, it's the same with periodontal disease. In order to be successful, the periodontally diseased patient needs to know where is the bone loss, how difficult are those to clean. We mentioned earlier that flossing doesn't help in a 6-millimeter pocket. How do they use a water pick, and what does the water pick do for them? And where are those furcation involvements, and how are they going to access those? And how will they use the go-betweens or interproximal, the proxy brushes, and where can they access those? And how does the power brush work, and why is the power brush anywhere between 16 and 50 times more effective than the handheld brush? And we want to not just show them, but we want them to show us. So staining the plaque on their teeth and allowing them to do a full mouth disinfection also demonstrates how long it takes to do that. So we tried to do all the behavior modification before the full mouth disinfection so that we can look for success following our scaling and root planing, and along with the antibiotic and the CTX4 treatment and any other treatment modalities that we choose during that time, whether it's laser therapy or whether you're using, we don't use site-specific antibiotic therapies, but you might. So in any event, we know that the self-prophy is a super important part of that. And again, measuring each time you see them what they've worked on. Now, this flies in the face of our typical treatment, which is we have one fee and insurance only pays this much. And so I think we need to rethink the entire paradigm of how we're structuring periodontal disease therapy, depending on the host immune response of the patient, how much nutrition coaching, the tobacco cessation, the genetic factors, are we working around skill development problems in elderly patients that have that don't have the ability to clean well, and how do we help them with that? So there are a lot of factors there. So last but not least, our oral health care team matters. The fact that we can put together a team of physicians in our area that can help us support patients to get healthier means that we need to look for other health professionals that share our values for optimal health, not just for putting Band-Aids on problems. And so that's an entirely other lecture, but I would love to help you with that sometime. I wanted to show this picture. This is our Wellness and Prevention Study Club. I'm missing them. We have our Zoom meeting tomorrow, and you can see Doug Thompson in the forefront. The rest of the physicians on my dining room table there are physicians. Doug is the only other dentist. But the woman with her hand over her forehead is a preventive cardiologist, a wellness cardiologist. And in this group are a number of other physicians, an integrative functional medicine doc, a naturopath, a rheumatologist, a pediatrician. And so when we look at who we're studying with and how we learn to speak their language and who we refer to back and forth, this idea that we could have not only a professional but a social network of people that could help us access the best part of our health community for our patients is a huge benefit to your patients, and in my mind a huge benefit to the practice. About 40% of our patients this year were referred to us by the medical community. We also work in collaboration with this group to do community events like this one. This is a Love Your Heart event where we invited the public and the local physicians to come together and meet with us. This is our team preparing for the Love Your Heart event, and we also did a whole host of cardiovascular screening exams during this, including cardiac intimate media thickening, CIMT, and we did A1C testing, and we did periodontal screening. And so we not only had speakers throughout the day, but we did screening and helped the public understand their heart disease risk. So these are really fun things you can do when you establish a network of like-valued and like-minded medical professionals that believe, as you do, that their patients deserve optimal health. These are, if you would like to continue to learn with me, I know they mentioned the Blabbermouth book, which was written for the public, but sold, I think, 8,000 copies to dental health professionals. The screening tools you're able to access, but if you'd like them customized, to be able to use those paper tablets to communicate with your medical professionals with your logo and identification on it. The hands-on learning lab, where we do self-prophy and 60 different science experiments with our kids from age 0 all the way up to the time they emancipate from their homes, whether they go to college or take a place in the marketplace working. We try to help kids really understand their bodies well. This year we will have graduated 44 of the kids we've mentored in our practice to dental school, which is just a huge feat for my team. An amazing, amazing accomplishment for us to turn that many eyes towards dentistry during the course of their growing up years, all through hands-on science experiences. And then Total Health Academy, which is an online learning platform where you can, it's a split screen, much like this. You have the slides on one side and you have me lecturing on the other, and there are 38 different modules of learning. They're all about this length, anywhere from 25 to 55 minutes, where you and your team can learn these lessons at home and take a little quiz and show up together and figure out how to implement. My gifts as a teacher, I have several limitations. So many of my colleagues humble me, and I'm blessed to be a part of an influencing board of directors at the American Academy for Oral Systemic Health, and blessed to share a stage with so many amazing people, many of whom you are witnessing on these Carry-Free webinars. But my gift is to help people put science into action. If you are really interested in integrating the science, implementing this in your practice so that you can be better clinicians every day, helping people learn how to, clearly how to help themselves get healthier against all odds in our world, Total Health Academy would be something for you to look at. You can Google that and take a look. It's during the rest of this month over COVID, it's half off and you own it forever. So a lot of people have jumped on that. It's been fun to see people get excited about at-home learning during this, as you are doing today. And without further ado, I just want to say in behalf of my team members, we're wishing you well, cheering you on. We're here as a resource for you. We are all eager to get back to work, as I know are you, and surrounding what is it going to take to do that. And that's a whole other set of questions, isn't it? But that's my cell number. You can text me today and let me know how you liked this, or you can email me, or you can ask questions. And I've never had more time than I have right now. So I'll turn it back to you, and you can tell me if you have questions that came up during this.
Thank you so much. That was a great presentation. We do have a lot of questions coming in, and we have a few minutes, so we'll get to some of those right now. Deborah is wondering if you make any of the visual slides available for use in our practice.
I certainly could do that. Deborah, if you want to email me, I can use a WeTransfer and do that. I can also give you the links to some of those. Mm-hmm.
All right, here's kind of a long one. It feels overwhelming to me as a traditionally trained hygienist to know where to start with my patients. If I was going to go back and do one or two things when we get to work with patients again, how would you suggest I start the conversation?
I love this question. Thank you for who asked it.
I don't have their name.
Okay,
sorry.
That's fine. I love the question because this has been something I probably should have touched on. Right now, we're probably going to want to go back to work without the use of our ultrasonics. And yet, there's going to be calculus there. So what do we do instead? Right now is a great time to ask questions to really, before you take patients back, about what have you been thinking about your general overall health in regards to your ability to fend off a virus like this, and how would you like to be healthier, and what questions do you have about that, and how could we learn together? The idea that you don't have to be the resident expert on their health if you're a learner, you're just beginning. One of the questions I always like to ask, instead of what changes in your health history have you had, because most people don't even know what health history you're looking at, and typically they're locked up in your computer somewhere, is what's most interesting to you about your health, or what health challenges have you been thinking you'd like to address? So just to be a learner with them and to help them access information. And if you are curious about doing some more research in their behalf while they're not there, to take their cell number and to text them later and to help them answer questions and to partner with them, as well as self-prophy. This is a really good time, since we can't use our ultrasonics. We'll be doing some hand scaling. This is a really good time for us to revisit how you're caring for your own teeth. And I would love to watch and assist you, so that if we're ever in another pandemic like this, and let's say it lasts longer, you're armed with much better skills and resources to be able to care for yourself. In fact, to be able to do that every single day. So those are some ideas I have.
Yeah. Len is, sorry.
Oh, hey, Lacey, let me interrupt you real quick, because you and I have not discussed this topic, and while we're on this topic, my question was, what are your thoughts about selective polishing?
Kim, you already know. Thank you for asking. I think most people have heard of the word selective polishing. They don't practice it. Selective polishing means we polish for stain and stain alone. That means we polish for the uglies. And by the way, does stain hurt your teeth? Is it pathogenic? No. So the fact is, polishing is way overdone. And the idea now that we don't need to be polishing, this is a great time to say, we've known for a long time that there was no clinical efficacy in polishing teeth. And this is a really, really good time to have the patient be able to use a toothbrush prophy to make sure that they're good at plaque control. So thank you so much for asking that.
Yeah, thanks, Susan. I mean, I'm thinking that, we're going to be having a whole different, conversation with our patients after this pandemic, right? And if you're not doing selective polishing yet, I mean, there's no evidence. If you've got a clean tooth with a healthy biofilm on it, and there's no stain or calculus, you should leave it alone, right? And so
exactly.
One of the challenges we got is patients, it's kind of like, if you haven't, well, you didn't clean all my teeth. Well, we need to re-educate our patients to the point of a prophy is really about cleaning the spots that need it and leaving the healthy stuff alone. And maybe it's a good time for us to start that conversation, because I know that's going to be a challenge for a lot of people, for hygienists and patients alike. Anyway,
yes, and let me say a little bit more about that, because it was there was an old study that said if we removed the biofilm, we had better penetration of the fluoride gels. We don't use fluoride gel. We use fluoride varnish if we're using fluoride there. And what happens is that the biofilm actually sets up a better scaffold for deeper and longer penetration of the fluoride into the tooth. So there really isn't any reason to polish a tooth except if you're trying to take a shortcut and get rid of heavy plaque. But if you have a patient with heavy plaque, aren't you helping the patient so much more by teaching them how to remove it? That's akin to teaching a man to fish rather than giving a man a fish, right? You're teaching a man to fish so he can help forever. So I really think this is a perfect time to back up and say, let's really help today. Let's do something different. And the other thing you mentioned is patients' expectations about polishing. We grew up that we'd leave the dental office with really slick polished teeth. It would only stay that way for an hour. But every 6 months, you'd get that slick feeling for an hour, and we liked it. Right now, most of my patients get fluoride application because most of them have dry mouth or root exposure or high sugar content in their diet or acidic foods. And so most people, and especially all kids, they're leaving with their teeth feeling like sandpaper. They're not expecting smooth teeth anymore. So, you know, again, we can also work with patients just to say, that's old news. New news has been for a while. The polishing teeth really doesn't help. We've been doing it to help because we thought it's what patients needed, but we're really going to start focusing today on the science and what's best for you.
Yeah, you know, Susan, the interesting thing there about that whole fluoride conversation is the fluoride's not, it's bound to the tooth by the pellicle, and it's not bioactive really, and you don't get any uptake unless you have a pellicle present. And the only time you don't have a pellicle present is when we've polished it off. So I mean, it's so stupid that we do fluoride treatments right after a prophy, and that's the only way that insurance companies will pay for it, and it's probably the least effective time to ever put fluoride in somebody's mouth, whether it's a varnish or a gel or whatever it is. So, I mean, there's a lot of restructuring that we need to do, but the irony is here we are doing all these fluoride treatments without a pellicle when we really need the pellicle for the fluoride.
Kim, you play the banjo. I think you play the banjo. I think the two of us ought to have a two-man group, and we'll figure out how to harmonize because we're the only two singing this tune, but we sing in unison. I would love that.
Yeah. Well, we could. Yes, we could be like Peter, Paul, and Mary without Peter.
Yes,
and,
we could.
Be,
I
or
love
Donnie
it.
and Marie Osmond, right? Okay.
There you go.
Right,
There you are. Sunny and
Lacey,
Cher. All right.
Yeah. So,
Okay.
Lacey, we got time for one more question.
Okay, we'll do one more question. Do you recommend scheduling longer hygiene appointments with our diabetic patients?
I recommend treating diabetic patients differently, watching for periodontal disease, making sure if you're going to treat active disease that you're doing both. You definitely need, if they're active hyperglycemia, in other words, they're not controlled, that they need to be medicated with antibiotics, and the antibiotics ought to be specific. If a patient is diabetic and their hyperglycemia is well controlled and their periodontal disease is well controlled, they should not need longer. I'm going to go back to the very first slide I said, which is we need to shift from a routinized examination to a personalized examination and act accordingly. I don't believe everyone needs an hour. I think most of our patients are in an hour because we do a lot of facilitation, but I say there might be someone that needs 50 minutes and someone that needs an hour and 20, and we should be able to charge accordingly, according to what we do. Now, I know that isn't the current paradigm, but, you know, there are people with all different levels of host challenge and skills, and we shouldn't be thinking that they're all cookie cutter and that everybody fits into an hour. So that wasn't an easy answer for you to hear, I'm sure, but in an ideal world, we'll be doing things ideally for the individual, not for our schedule.
Right. All right, before I get to our wrap-up portion, Dr. Cooch, do you have anything you'd like to add?
No, Lacey, I just want to thank you and thank the Carry Free team. You guys are just amazing at what you've done. And Susan,
Amazing.
you are such an inspiration as a clinician and as a person, and I just really applaud you, and thank you so much for doing this today.
My absolute pleasure. Hats off to you guys for doing this, and I'm so excited about using the CTX4 as a pre-treatment rinse for COVID. I don't know if you guys have bought it yet, but it's a killer for COVID, and we just bought a shit ton of it, pardon my French. So I hope I beat you to buying it, and we can get it soon. So good luck with that.
That's awesome. Thank you so much. All right, so before we let you guys go today, I have just a couple of things to mention. Please join our Facebook group if you haven't already. You'll be directed to the link after the session today. We're posting the recordings in the group and also emailing them each day with the CE info. And for the CE, once you complete the quiz and evaluation form, you'll get your certificate within a 1 to 2 week window. We did have some questions that didn't get answered today, but Susan has included her contact information on the screen, so you're more than welcome to reach out to her. And don't miss tomorrow's course. We have Dr. Bonnie Feldman speaking about why the oral microbiome is key to overall health. Thank you, everybody, for attending. We're having so much fun bringing you these courses and giving us all a bit of distraction from what's going on around us. Have a wonderful day, everyone.
Yep. Bye-bye.
Bye-bye, everyone.